Well, look, hello and welcome, and it's really very, very good to see you all. It's my pleasure and privilege to be chairing this event, which has been put together by Martin Powell and Judith Smith from the University of Birmingham. It's triggered by next year being the 50th anniversary of the Ely Hospital inquiry. The first, so to speak, of the big NHS inquiries, and certainly the first public one. The format for this is built around 5 academic papers and 2 panel discussions. An opening overview from Martin Powell.
Some of the themes that come out, or some of the recommendations that come out, well, culture comes out very highly. If you do a content analysis of inquiries, the word culture comes out quite a lot. And in one way, it's a great answer, culture. But then the more difficult question is, well, okay, if culture's the problem, how do you change the culture? So assuming that one of the key reasons for an inquiry is to learn lessons and prevent similar events from reoccurring, clearly that suggests a focus on the recommendations of an inquiry. So in one sense, the recommendations must have 2 characteristics. They must be implementable and they must be implemented. So the questions that I'd like to try to at least address sometime during the day: have some inquiries been more successful than others? And if so, is there something we can distill or bottle from them? In other words, is there some sort of success factors we can take to try to make, better use of inquiries in the future?
So why was Ely different? Ely had the same status as the Sans Everything inquiries. It was different not because of its allegations, they hugely overlap with all the others, but because of the different people and their different attitudes. And I think having time to prepare their strategy.
What brought about this awful state of affairs? The Trust Board was weak. It did not listen sufficiently to its patients and staff or ensure the correction of deficiencies brought to the Trust's attention. It did not tackle the tolerance of poor standards, the disengagement of senior clinical staff from managerial and leadership responsibilities. You can see that then adds that those failures were due to a focus on reaching targets, achieving financial balance and seeking foundation trust status at the cost of delivering acceptable standards of care.
We're still too far away from treating patients and family members and neighbours as partners. We're still too far down the Einstein ladder of pub. We're seeking feedback. That's not good enough.
There are no established competencies for senior directors. So if you want to become a senior director, how do you prepare to do that except for somebody coming up to nudge you and say, well, Charlie, it's your turn, would you like to step up to the board? And it seems to me that is also a challenge to diversity, because if you can't see what the competencies are that are required, how do you ever attain them and then reach for them?
The inquiry that followed events at Bristol Royal Infirmary found the existence of a club culture. This operated largely at managerial and board levels, and entry to the club was dependent on the length of service and fit with the executive team. This resulted in all the decision-making power being held by too few individuals. Appreciating the complexity of the task means accepting incomplete control, but it does not mean we have no control. Again, to go back to the Kennedy report, problems should be seen as responses to circumstances. Change the circumstances and there is the prospect of resolution.
The role of public involvement depends upon the relative value of data versus patient experience, and that actually, inevitably, there will be political considerations, because perhaps the most political aspect of NHS public inquiries is the relationship between an NHS organisation and the public it serves.